Good afternoon, and thank you for joining us today in this image challenge live stream from a retina physician. My name is Marianeli Rodriguez. I'll be your host today. I'm a retina specialist with Retinal Associates, and I practice in Massachusetts. I have no financial disclosures. So I'm joined today by Dr. Jay Sridhar, who is joining us from Miami. I'm so happy that you're here with us, Jay, today. Welcome. How is the weather?
Thanks for having me, Mari. It's hot. It's getting really hot.
Yeah, we had a little bit of a heat wave here, but now it's cool again. So I'm hoping it warms up again. Anyway, I wanted to discuss this case. It's not so much of a image challenge, but more of your thoughts about surgical management. I met this lady, very lovely, 87-year-old, that came to my clinic complaining of vision loss. And her vision was 2300. She noted a decline for about 3 to 6 months. She had normal intraocular pressures. She was pseudophakic. And this was, when I examined her, this was the fundus photo and the OCT that I got in my clinic at that visit. So Jay, I would just like to hear your approach to a patient like this. First, your diagnosis, what kind of questions do you ask of a patient like this? So yeah, walk me through it.
Yeah, great images and a great case to discuss, because this is tying into what's the most common procedure that vitreoretinal surgeons do in the United States. So this looks like a case where you have, in the fundus photo above, you have that whitish sort of plaque-like lesion over the macula involving the fovea, just to the left or temporal of the optic nerve. And then in the OCT image below, we can see that corresponds to a pretty thick and fibrotic epiretinal membrane that also has a component of vitreomacular traction. The hyaloid is still down and attached to it. And then you can see pretty significant thickening of the fovea with CME. It's hard to tell from here whether there's a component of subretinal fluid there too, like a localized tractional detachment.
Yeah.
Yeah, but at the very least, an extremely thickened macula secondary to the traction.
Yeah, so I mean, this was a pretty extreme case of combined VMT ERM. Usually the ones that we see are not as significant, and we still take them to the operating room. So I just wanted to hear your thoughts. When do you have a threshold for taking the patients to the operating room? Is there a vision that you kind of consider when taking them to the operating room? What kind of discussions do you have with them about that?
It's an interesting question, Mari, because I think that I said it's the most common procedure that vitreoretinal surgeons do in the United States. That being said, I tell patients the vast majority of epiretinal membranes don't end up in the operating room. Now with OCT, we find more and more of these membranes that don't really affect vision or are stable for a long time and don't necessarily merit removal. At the same time, we get the referrals as retina specialists for the epiretinal membranes that are progressive, that are causing visual issues such as distortion, blurry vision, or metamorphopsia, or distortion of straight lines. And for those patients, I do have the discussion about surgery. I think the decision, in the past, people used to have strict vision cutoffs, similar to cataract surgery, where they said, if your vision's not worse than 20/40 or 20/50, don't do it. But, with modern vitreoretinal surgical techniques and better imaging, we understand that you can have a 20/40 patient with an ERM, where the ERM is not the reason for the 20/40 vision, and maybe you shouldn't take them to surgery. And you could have a 20/25 patient with an ERM who can see the eye chart, but has significant distortion, significant metamorphopsia, and the ERM is the causative issue. And so I think one of the first things as the clinician is just distinguishing, is that the cause for their visual complaint? And that's really boiling down to how much of it is about distortion? How much is it about curving of straight lines? And then in the exam, looking for anything else that could affect the vision, right? Do they have surface disease or a cataract or anything else that can impact it? If you ruled out all those things, and then you have that match between the OCT appearance, what they're saying, and the exam sort of matches, there's no other cause, then I think it's reasonable to talk about surgery. I'd be curious what you do, Mari, but I really undersell epiretinal membrane surgery to patients in the sense that I tell them it's a very safe procedure with rare risks. It's very successful in the sense we can get rid of the epiretinal membrane, and we have good techniques to prevent it from regrowing. But it's not 100% slam dunk guaranteed that they're going to be satisfied with it, because there may be a component where the retina is not as plastic as we want. We take that ERM off and it doesn't return to its initial form. Most patients in the studies we've learned, remember that number is like 75 to 80% of these patients feel like they improve. They get some improvement, but it's not everyone. And if a patient hears all that and they're sort of balking, I don't push them into surgery. Like if I saw this person and they were kind of like, I don't know if I want to do this yet, I say, look, it's not an emergency. This has been there for a while. Let's repeat a scan in a few months. If it's somebody, I'm sure this patient had seen someone we referred to who's seen a couple people, they've thought about it, they're like, I want to do it, then I think it's super reasonable at this point to take them to surgery. So a lot of it depends on the patient response, but I'm not sure how it goes up in New England.
Well, I approach it very similar to you. I'm more of like, how is this affecting your daily life? I asked them about diplopia. A lot of the patients that I take to the OR complain of that, trouble reading, basically one image kind of running on top of the other, that discordance between one eye and the other. Metamorphopsia is a big one for me when they are, really, just things don't look straight anymore, and I just really cannot function like that. So I do, when I talk to them about surgery, I do very much like a functional approach and not so much by how the OCT looks. Because I agree, sometimes you look at an OCT and you're like, oh my gosh, I'm sure that that's like a 2100, and they're like 2025, they're not bothered. And then sometimes a membrane that doesn't look too bad, the patient is really bothered. So I try to do more of a functional assessment when I discuss with them before agreeing to the OR.
I think those are great points. I think there's two other components of this case specifically. Number one, the presence of the combined vitreomacular traction with ERM actually makes me feel better about taking this patient to surgery, because let's say something happens or the peel is really difficult and that membrane doesn't want to come off. Even if you just get the hyaloid off of it, this may get a lot better, right? So the chances of success are actually a little higher here. I think the other really important factor is just considering if they're pseudophakic, for example, in a different case, like what does that look like? Because a lot of patients now have monovision or they have multifocal IOLs, and they're going to be a lot more bothered or symptomatic than if they're a patient who's got standard monofocals with equal on both eyes. If they're a monovision patient and this is their reading eye, they're miserable, right? If they're a multifocal patient with reduced contrast sensitivity, they're probably pretty miserable with this. And so those may be considerations to weigh more, be like, okay, it looks bad on the OCT and they have this other factor, I'm more inclined to take them to surgery.
So what about if a patient is phakic and they do have some, what you deem significant, cataract? Do you do a combined surgery with, with an anterior segment colleague? Do you do a, stage procedure where they do the cataract surgery first, or do you do the ERM peel first? How do you approach that?
That's a fantastic question. And I think if you ask people across the world, you're going to get different answers, right? I think in the US, most people split the surgeries. Most people would do vitrectomy and cataract surgery separately. And part of that is referral patterns. Part of that is just access. I don't know how it is where you operate, but you may not have access to an IOL library or an IOL master, all the things you need to do the phaco at every place you operate. I work at an academic center, so I have access to all of these things. Even so, I don't do a ton of combined phaco peels. For me, both have to line up, right? So like if I'm borderline, like this is a very obvious case where the vision is being affected. But if it's a borderline ERM and their vision's down and they have a cataract, I say, look, go get the cataract surgery. It's the quote unquote simpler surgery to have. And if you have that and you feel good, then great. You don't have to have that other procedure. I don't need to operate on you. And if you come back and you're not happy, it's super easy at that point, much easier in a pseudophakic patient to do a vitrectomy. If they have a bad ERM and the cataract's not too bad, then I don't force them to have cataract surgery before. I say, look, get the epiretinal membrane fixed, and then we'll do the phaco later. The only situation I'll recommend the combo is, number one, there's some sort of insurance or travel reason where they can't go back to the OR easily twice in the span of a few months if one doesn't fix the problem. Or two, let's say it's this patient, very obvious issue with the macula, but let's say they also had a very obvious significant cataract, like a big PSC cataract. Well, then I think it's reasonable to kind of combine them. I have access to that, but I understand a lot of people don't. And I think it's okay to split. There's never really a disadvantage from a medical standpoint to separating the surgeries.
Yeah, I mean, those are all great points. I don't have, I'm in a retina only practice, so I don't have access to, I can't remember the last case that I did that was combined. I think my partner, Brian Hong, has done some combined cases, but, it's not as feasible. Our schedules are very different from our colleagues. But, for me, if I think that there is a significant cataract, I agree with you. I usually tell them to do that first. And my rationale is that, sometimes one surgery might fix the problem. If I do the peel, you will need 2 surgeries for sure.
Right.
So,
right.
So let's see if you can get away with one rather than knowing that you will have 2.
Yeah.
So
the other point I would make, Mario, before we move on is, and I forgot to mention this earlier, one of my attendings in fellowship taught me this, and I'm sure you heard this too when you trained. I think most ERMs are idiopathic. You look in the periphery, the retina is fine, there's nothing else going on. But I would always recommend a good peripheral exam, because the number one thing that could be a cause would be a retinal break, a localized detachment. And I've had ERMs referred into me as pure ERMs where I've done a peripheral exam and I found a tear or localized RD. And that's huge to know as a surgeon going into surgery that, hey, I might actually encounter a problem in the periphery, or I may have something else if the ERM is not significant that I could treat in the clinic. So I just wanted to make that point.
Yes, no, that's a really good point. And I have had the same thing happen to me where I'm examining and, bread and butter ERM. And then, I'm here doing something totally different for the patient and recommending a totally different surgery or procedure. So that's a great point. And then once you're in the operating room itself, this is like, here definitely that the hyaloid was down. So I had to, induce a PVD. Do you stain? Do you use triescence to look at the ERM? Do you peel the ILM? What's your approach?
That's a great question. I'll start with the caveat. If they're diabetic, I don't necessarily peel the ILM, because I think that they can have issues with removing the ILM sometimes with collapse of the inner retina. If they have diabetic retinopathy. If they don't have diabetic retinopathy, I like to peel ILM in my ERM cases to prevent recurrence. And in those cases, I do like to stain. I use Brilliant Blue, but I think ICG is reasonable too. Some people use Triessence to market. I probably would induce the PVD without any stain, because I don't like to use Kenalog if I'm going to stain with a vital dye, because sometimes it obscures the contrast. So I'd probably lift the hyaloid, then restain. The nice thing when you have vitreous macular traction with an ERM, a lot of times when you lift the hyaloid, it actually fractures the ILM or the ERM. So you get a nice plane to start your peel with. It's not the same as starting and pinching and peeling or initiating a flap. A lot of times I think the flap will get initiated for you. And sometimes you get lucky and you pull this off and the whole ERM comes with the hyaloid too. Then you're just peeling ILM for recurrence. But I like to peel ILM. I don't know about you.
Yeah, I usually always peel ILM. I usually do Kenalog or Triessence, whatever is available to stain the vitreous as I induce a PVD. And I use green ICG when I'm going to be peeling. And then do you do pinch and peel, or do you use a Tano or create a flap with something else?
Yeah, there's so many ways to do a flap. I like peeling. I find it reproducible. I know some people use a loop or a Tano or an MBR blade initially, but I like pinching and peeling. And then where to start is always a question. I feel like when I was in training, I was always the thing I was thinking about was like, oh, I go here, do I start here? And as time goes on, it's really not helpful for trainees, but you sort of realize that you kind of just take where it's showing you. Sometimes you have an area that stains really well or an area with an opening, but all things being equal, I think the most ergonomic place is usually 180 degrees from where your dominant hand is. So I'm a righty and this is a right eye. So if I'm doing a right eye surgery on this patient, probably the easiest place to begin is somewhere inferiorly, because it's a way for me to go and peel. The other thing is that was taught is when you stain, you're going to get a negative stain wherever the ERM is.
Right.
And I was always tempted to go right at the edge of the negative stain time you see the color, but it's actually one of the hardest places to get the ILM free because it tends to be very tight and sheer right where the ERM inserts in it. So actually go a millimeter or so beyond that. And then if you initiate an ILM flap, you can get the whole complex to go. So don't start right at the edge of the negative stain, go just a little bit beyond it and you'll usually get better traction.
Yeah. And how wide do you do your peel? I've seen when I was like in training, there were like 16 attendings that I worked with and everybody kind of had their own, like how far they peeled. Some people did like from arcade to arcade. Some people just like did it around the macula. Some people were just like, okay, just as long as the fovea is off, that should be good. What do you think?
So I would go with the latter. I think that we always, and this is my humble opinion, we always have to think what the goal of the procedure is, right? So this is not a macular hole where the goal is to reduce the ILM traction, to help the hole close, or whatever we think that. We don't know for sure how that works, but that's what we think it's how it works. In ERM, you're essentially trying to reduce their distortion and get better foveal contour. So I think as long as the traction is off the fovea and the perifoveal area, I mean, if it's sitting there and it's standing up, I'll go take that ERM or ILM a little further out. But I always joke as I'm doing it when I'm talking to a fellow, it's vanity points. It's sort of like, you're doing it because it's there, but you don't have to. And I think also you can get yourself into trouble. Like, I think we've all had these patients where you'll have an ERM that keeps going. It will go to the arcade and it will go to the periphery. And if you keep going, you're going to tear the retina at some point, especially if it's an odd or an eye with history of surgery or a diabetic retinopathy eye. So I generally just get it off the fovea. Anything else that's easy, it comes off, I'll take it. But you don't need in my opinion, you don't need a huge circumference around the fovea. But again, there's many different ways to approach this.
Yeah. And then at the end of the case, let's assume there's no breaks or anything. Oh, another question I had for you. How much do you shave when you're doing a case like this? Do you do a shave at all?
So I've evolved a little bit. There's some literature from Japan where they don't even do a vitrectomy. They go in with 27 gauge instruments, they peel the ARM, take it out of the eye and come out. And those patients seem to have good outcomes when they publish it. Now, that's a little too much for my taste. I'm a little more conservative. But here I would lift the hyaloid, I would peel the RM. And then if the periphery looks normal and the hyaloid has come out nicely, I wouldn't shave. I would just clean up what's accessible to me with each hand. I usually like partial air because I like that just to check my sclerotomies, and I will get out. I always reserve the right. Like if I see anything funky, like if the vitreous is super sticky in the mid periphery, if there's a break peripherally, then I will obviously shift course. But normally ERMs, I don't shave in the periphery.
Yeah. So yeah, I think that there's consensus about that. And I also do a partial fluid exchange when I'm doing this kind of surgery as well. And I always tell the patients before, tomorrow you're going to not see very well. There's going to be a bubble. It's going to be worse. But, I don't know. I mean, maybe I'm just like being a little bit, there's like witchcraft here in my mind about this whole thing. But I feel like when there's air in the eye, it also kind of like helps smooth things out.
Yeah, so that's a great question. Yeah, so I had attendings that going to vary when I was in training, and some would be like, "Oh, I'll put some air and put them face down, and maybe we'll push it into place." And other attendings who like wave their hands and be like, "That doesn't work at all. That doesn't make any sense." So I don't do positioning, but I feel like I cheat in a way by leaving some air in there. But if there's a lamellar hole, I've actually switched. So I will actually not only leave air, I'll put an ILM flap over the lamellar defect and I'll put them face down. And I've had a couple of those. They look really good afterward. And maybe it's just lucky or anecdotal, but whatever. But I'm just like, maybe if they have a little defect, you leave some sort of scaffold. It's okay. This one is pretty tented.
Yeah.
Maybe you put them face down. I think no retinal surgeon ever said no to a patient being face down overnight. I think that it's like water for retinal surgeons. For me, the bigger question, Mari, is do you give anything else? Like, are you going to give them subtenons or intravitreal steroid? Like, what do you think about that component? Like, do you think that's important or not? Do you put them on topical nonsteroidals after, or do you think this is purely tractional and then you figure it out later?
Well, with her, we'll talk about her post-op. I thought it was mostly tractional. And, once I lifted that hyaloid, things kind of like settled down so nicely.
Yeah.
That I was like, I didn't see any like inflammatory reasons why she had this. And so I didn't do any like, intravitreal or subtenons catalog.
I'm with you. I mean, she's phakic. I mean, and ideally you put off her cataract surgery as long as possible.
No, she was pseudophakic.
She was pseudophakic. Okay.
Yeah.
Okay.
So, but she did really well. But sometimes I do think that NSAIDs do help, and I sometimes put them on if I feel that there's like cysts there, and in the post-op OCT where I see that I was able to peel really well, but there's still cystic changes. Sometimes I just put NSAIDs. It's not going to hurt anything. So I just do 4 times a day. So this was great discussion, Jay. So if we can show the post-op month 3. So, she was.
Oh, wow. She had a great surgeon.
Yeah, she was 60, very happy with her vision. So, we felt that this was a success. So thank you, Jay. I appreciate, your pearls. I'm glad that you came. I hope we have you again at some other time.
Thank you for having me. I love this show, and great case, great surgery. I appreciate it.
Yeah, thank you. Okay, bye everybody. Thank you for tuning in today, and you can leave us a comment online via our multiple platforms. And we also hope to see you again soon. Thank you.